Okay, just quickly, for those not familiar, we are the National Center for Health and Public Housing. We are a HRSA grantee. The opinions and information expressed here are not necessarily those of HRSA. The National Center for Health and Public Housing is dedicated to improving health outcomes and wellness of residents of public housing and other HUD-assisted folks nationwide. And we do that through a combination of training and technical assistance, research and evaluation, and partnership building. Presenting today will be David Wagner, and David is somebody that we have worked with before and has a kind of a broad experience. He's a longtime health center and healthcare leader, and consultant in finance, reimbursement, management, HR, operations, and the HRSA Health Center program requirements, with direct experience as a health center COO, CFO, and HRSA site reviewer, as well as additional experience in diverse subject matter from value-based healthcare to the social determinants of health. We were very excited about doing this session. We had an awful lot of discussion over the last couple of years with our health centers out there, dealing with a lot of struggles on all issues having to do with revenue and cost and productivity and of course, staffing and workforce. And it seemed something of great interest and great need, and kind of summing up what happened in the past couple of years and lessons learned, and then dealing with how we might be prepared, going forward, through the development of response plans and all that kind of stuff, not just for COVID, but for whatever the next big thing is, whatever the next big emergency is. And so at this point, I'm pleased to turn this over to David Wagner. So David, I'm going to stop sharing and you can start sharing.
All right, how's everybody today? So I think we missed a couple of brief slides. Basically, we did I'm going to do brief introductions now, and then leave some time at the end for more of a work group type format. I think you mentioned the health centers, how many there are, and how many people are close to public housing, quite a few. So this is a very timely topic. So what we've done is we put together a series of seminars to discuss finance and operations and how COVID impacted us. I don't want to sound like I was lucky enough to have been in Katrina and helped health centers recover back then, but I feel like that experience gave me a very, very, very good training on not only how to prepare for the next issue, but also how to do a lot of the things that we're going to be discussing today, like retrospective review of what happened, then using that data to project forward what could happen. So I'm really excited to be able to share this with you. All of us went through it with COVID, and it was significantly different than what we experienced in New Orleans with Katrina, because it was the whole nation, actually the whole world, that was going through this. So, it prepared me, but I did learn a lot that I want to share during these sessions. So today we're going to really concentrate on the revenue issues. In a future session, we're going to talk about cost issues. We're also going to talk about staffing issues, and then finally productivity issues. And some people bulk productivity in with revenue, but I think you'll find shortly why I separated those out, but primarily because there are different revenue sources than just patient revenue that we're going to cover. So the first Menti, I always find it interesting, the timing of when all this happened. And I was actually working in a health center up in the Northeast when it occurred, but I had clients still across the Midwest and the Deep South. And it was interesting to me to see how it kind of went in waves back and forth across the company, almost like a country, almost like a swimming pool. So the first Menti question is, when did COVID-19 cause you to abruptly alter your operations? And I don't mean when did you start seeing the financial problems, but when did you have to close? When did you have to lay off staff? When did you see the significant just stop of patients coming in, things of that nature? So I'll leave a few minutes for people to answer that question. And I'm not sure how to show the responses to that. Maybe you can guide me.
Fide, how would we get the results on the screen?
Will I stop share and then yours will show up?
I don't know.
I didn't think about that one. Minor details.
Yep.
If that doesn't work, maybe we'll have people chat in the answers.
Fide? Yeah, I think people are somebody just sent a message. I think some people are still trying to get to Mentimeter and actually.
I got you. Okay. We'll give it a few seconds. Okay. Uh-oh. Deborah said wrong answer. No, there's no wrong answer to this. But maybe we'll do is Fide, if you want to let me know how to fix that for the next ones. And I'll go ahead and move on because we don't have much time.
People can put that in the chat. So in fact, Deborah just put something in.
Yeah, that's perfect. Okay, March. Yeah. And the reason I bring that to light is because one thing I learned with this experience is it's very important to watch what's going on in the rest of the country and have counterparts and peers that you can have open discussion with in other parts of the nation in case something like this ever happens again on a nationwide scale. Because I was able to actually prepare my health centers in Arkansas, and they were already responding to it before all of the issues actually hit them because of what I went through up in the Northeast. And I'm seeing March 23rd, the city went down, lockdown, that's right. Okay. Anyway, so that's one thing that's very important. So what are we going to explore in this whole series? We're going to survey the effects of COVID-19. And I know we all did the HRSA surveys and we've kind of absorbed that information already. I've actually got the data from UDS, from other different places to share with you some of the other effects that we're seeing across the country. And again, more on a national level. Then I'm going to help you identify the factors that your particular health center experienced and then formulate a response plan. I use the HRSA emergency plan as basically the cornerstone of how we would do this process. So we'll explore that together, and hopefully by the end of this, you'll be able to put that plan in action for yourselves. And then we're asking again about when did you have the most significant operational impact? If you want to just keep putting that into your the chat window, since I'm not sure how to run the Menti, that would be great. And I'll come back to those. And then what was the most significant impact you experienced? I think some of you guys answered that question already when you signed up. So I did review those. And it seems like everybody had the same types of things we're going to be talking about in the whole series. So again, those are the takeaways for the series. Now, as we are moving into the revenue session itself, what we're going to talk about is the specifics of COVID-19 on revenue. I want you to then kind of think about these things as we're walking through them to understand how those factors affected your individual health center. And of course, there could be one, two, even several of those. And then start thinking about the revenue portion of the response plan. So we're going to get into some things you can start preparing for now to make sure you've got that revenue down. All right, so first, what is revenue? Revenue is the total income produced by a given source. So that can mean revenue from yourselves, that can mean revenue from payers, that can mean grant revenue, that can be donations. I generally think about it under the HRSA definition. Part one is patient services revenue, usually stuff you see on Form 9D of UDS. And then there's other income. That's normally what you think of in Form 9E of the UDS. The federal government grants, contract contributions, and then of course your own retained earnings that you may have. So what happened with revenue across the health centers from 2018 to 2020? This is in billions. You can see 2018 total revenue, and I have to give you a caveat. I've stripped out capital grants because I don't really consider that operating revenue. And really what I'm addressing here is operating revenue, the lifeblood of the FQHC. We were at 1.3 up to 12.1 in 2019. And then look where it dropped to. And again, this is operating revenue. This does include grants, just not the capital grants, 9.9. So you see, even though we were shored up by some grants, we still lost as a nation. And here this is illustrated. The 9E other is everything except for the 9E 330. So in 2019, we were balanced about 4.6 in other revenue, about 4.9 in HRSA grants, and about 2.5, and again, these are billions across the country, in patient revenue. That's Medicare, Medicaid, private insurance, and self-pay. But look over here what happened. The other revenue dropped significantly. We got some COVID relief, but this is what was paid out during 2020 and reported on UDS reports. So I want to give you that disclaimer because it doesn't match with what you may have heard in the popular press that the health centers may have received in revenue. Maybe they got some of that in 2021, or they didn't report it on the UDS report. So that's a caveat. But look at the patient services revenue. That didn't dip that significantly in 2020, which was very interesting to me when I started looking at this. And then of course the 330 revenue, again, not including grant revenue, was up slightly because we all know that we got a couple of those little extra expansion grants. To the point that I could, all of the HRSA COVID money is up in this 1.31. So let's dive a little deeper and see what those trends were. These are the breakdowns to show you between the payers for income, specifically patient related. 2020, Medicaid only made up 61%. I know that's what most of our health centers rely upon, while in 2018, that was 65%. Notice that private pay was up a hair from 16 to 18. Medicare was actually up a hair from 11 to 13. So it looks to me like what we lost in Medicaid revenue shifted to private and Medicare. Now, why is this important? And I'm going to come back to this once we get to the last section about putting a response plan in place. It's important for your health center to know your specific revenue mix, because what you're going to want to do is have that laid out. I would invite you to retrospectively review what happened to your health center month by month by pulling that table 9D over 2019 and 2020, so you can kind of see when your downturn happened, what revenue was affected the quickest, what revenue stopped, what revenue shifted. And what you're going to see is services by payer type and revenue by payer type. So you can kind of read into, was the telehealth impact as significant as I think it was? Did it shore up? Did it go away after the emergency is now ending? These are the types of questions you can ask yourself so you can be ready for the next one. Just so you can kind of model what those impacts could be. And then here's the other revenues. This is that table 9E. that we were speaking about. Notice, of course, I do have it in 2018 and 2019 for control, but there's no COVID revenue, right? But look what happened to the non-federal grants. That went down a hair. Other federal went up. I have to tell you that probably some of the COVID money got classed there, maybe improperly on the UPS reporting. That could also be some of that COVID revenue that was from the federal government, not dispersed, by way of some of the practice, the additional practice money that was given out. So I don't know exactly where that was, but it did shift, obviously, in that time period. And then, of course, we went to the 10%. But what's interesting is then the Section 330 became a lot less, even though that didn't go down. It appears that some other revenue streams came in to kind of prop that up. Again, you're going to want to understand this part of your table, because we really don't want to, we want to know what happened during that event so we can project what might happen during future events. And the reason you need to have all this right at hand is in case it's something sudden like this again, you got to respond quickly and almost have like, and we're going to go through this, but almost like tabletop estimate of what would happen if a hurricane hit me, or what would happen if the power went out for a month in a whole region of the country, or vice versa, or God forbid we have another COVID wave. So that's what you're going to look at. So in summary, understand your revenue. Compare it to what we looked at it at the national level. Did you do this poorly? Did you kind of prop yours up quickly? Just kind of go back through and understand how your revenue shifted between 18, 19, and 20. And I like starting with 18 because that was a totally normal year. 19 was a pretty normal year, although the COVID frenzy kind of started right at the end there. Of course, 2020 was just a horrible year. You internally can compare your 2021 to see how you recovered. And soon we'll be able to see the 2021, all of the actual EDS report. We can kind of update this and make some information there. Look at how your visit types changed. And what I mean by that is on Form 5, look at, did you shift to more telehealth? Did you stay with live in-person visits? Did your optometry and dentistry, did those just basically stop? Did you increase your behavioral health? Just kind of understand those types of things as well, with the understanding that some services just could not be delivered. Now, I had an interesting situation where one of my health centers very quickly went on to behavioral health just because they were getting so many requests for people just to talk about things and work through things. And people were so anxious about COVID at the community level. That health center actually did better in 2020 than it did in 2019. And most of it was because of behavioral health. So make sure you understand those types of things so you can understand your mix. So let's talk about telehealth reimbursement. A lot of the times we work through things using Medicare. I know Medicare is a sliver of your business, but it's usually the precursor to what the privates will do. Not always, but at least it's usually a precursor. So they broke it down into 3 different types of visits. Oh, sorry, that thing keeps coming on. Telehealth itself is actually a replacement for the regular CPT coding for CMS, as well as for most of the private payers. That means synchronous communication, which means you can see the provider and the provider can see the patient, and you have live video and live audio going back and forth. Then they have a virtual check-in. That's more of a more of a way for you to just have a very quick visit. It can be recorded video, it can be by telephone. Um, it's not that synchronous requirement, but I will give you a caveat that has a significantly lower reimbursement than a true telehealth visit. Then there's e-visits that came up. These were very brief visits, and these can be non-live, so they can be just communications between providers and patients using chat or messaging or things of that nature. Those also came up. Those are even lower reimbursement. Um, so understand how your telehealth transitioned even within these reimbursement major categories. I'm really afraid that telehealth may be not going away necessarily, but significantly changing over these next few months because obviously the emergency is ending. So we have to watch this very carefully, depending on what area you're in, what insurance you're with, whether it's Medicare, Medicaid. And I'm going to give you some resources to try to monitor that over this next few months. Because again, this is going to be critical if you're depending on that to shore up your revenue. And we talked about the virtual check-ins. That was actually allowed in all areas over the telephone. E-visits, not even on the telephone, just messaging back and forth. So I don't know if you've come across this resource yet. I go to this constantly when I'm working with my clients across the nation that are heavy telehealth. A lot of them have actually maintained a pretty brisk telehealth practice, primarily in behavioral health, but not necessarily all in behavioral health. But this resource keeps up with the various telehealth rules and regulations across the nation and by state, and more importantly, by Medicaid. You see over here on the left, it's got search by filter. You can actually search your state, of course, whether you want Medicaid or other reimbursements, but also for Medicaid, is it live video? Is it just by phone? So I love this resource. So that's the URL to get to it. And I invite you to get really familiar with that one because you'll want to check that constantly as things develop. So we've talked about the revenue side. I do want to tell you that there is a cost side that we're going to dive a lot deeper into when we get into the cost section. But just keep in mind that telehealth, if you do it using the synchronous technology, you've got to have working technology at both ends. You'll need good souped up equipment at your end. And a lot of people say they can do it through the iPhone. And that works well if you're in a health center that's got really good, fast internet connection. But we found in most of the health centers I was with, it really worked better if the office end, that's the end that the provider is sitting at, is actually wired Ethernet into an Ethernet hub with good equipment on a computer, good video equipment, good audio equipment. Then on the other end, we found that it was better. And again, I'd love the conversation if you had other experiences, but we found on the other end, it was actually better for them to be on a cell phone, hopefully hooked into a Wi-Fi network, just because that was easier for most patients to actually operate, even the elderly. And I want to say right now, the elderly grabbed onto this and used it a lot of the places. So I personally have dispensed with that pre-held notion that the elderly don't like mobile apps and telehealth. We actually just went through a session with each one of them to pre-train them on how to use it before the provider got on the phone to make sure that their phone was working, all the audio was connected, and things like that. So we also found that in the rural areas, a lot of people really enjoyed using the telehealth technology, but of course it was more challenging if they didn't have a good Wi-Fi connection or a good cell signal. You'll have the service contracts, maintenance support contracts, and then of course there's a non-physical cost of telemedicine productivity and patient satisfaction that you really want to take into account, because the patient sat portion is what I just explained. You want to be able to help them use the telemedicine, help them use the app and the technology so that they aren't upset with it when it happens. And then of course also that affects the productivity. We found with one of the more popular free telehealth apps that if we didn't have a good stable connection on our end, like with a really good pipe for Ethernet, about a minute or two into the conversation, it would either drop our interpreters who are linked into it or drop the patient entirely. So that, you know, we experience those issues. So those are things you want to keep. You want to go back in time and look at that, analyze if your system really kept up with the technology it was needed, so that you can ensure you can use that in the future if telemedicine becomes one of the reasons to do it. So I'm going to go back to the chat, Minty. I'm seeing that several people had comments in reference to the costs, the provider costs went up. As opposed to being able to earn revenue on those providers. Absolutely. That's one of the things we're going to talk about in the cost section. The payer mix revenue changed significantly with, but they weren't sure if it was the encounter types or just the payers themselves. Somebody mentioned credentialing. That's an important thing with Medicaid. Absolutely. Let's see. A cyber attack, very good. Yeah, a cyber attack could also be a major issue that occurs that impacts operations and revenue. One says that telehealth was impossible because the center couldn't collect payments from the population. That's another good thing to keep in mind. The self-pay billing statements went way down. So they couldn't collect as much anymore in self-pay. All excellent examples. So if one of those was not something you experienced, you might want to put it on your radar. So let's move into what happened to me during this experience. And this is, guys that have seen me before, I'm a dashboarder by heart. I think it's really critical to understand exactly what's going on in your health center. This particular dashboard is something we continued to use during the COVID crisis. It measures the types of visits, the costs of those visits, the collectability of the accounts based on those visits. On another tab, it's got the payer mix. It's got the number of visits by payer class. So those are some of the things you could start measuring. And notice what we do is we measure against our current month's projection, which is our budget. And then we also look against last fiscal year. Now, I'm going to tell you to do a good retrospective review of what happened to your health center, primarily, and of course, I'm not ignoring quality, but I think quality gets a really good look by everybody throughout the health center just because it is primarily what gets published about us on the national scale. So don't ignore your quality. But what I want to do is kind of bring forward, let's look at these tables just as closely as we look at quality throughout. You're going to want to go back in time and look at this stuff on a month-by-month basis if possible. Table 5, of course, is your mix of patients. It's your mix of visits. And what I mean by that, people that don't know these tables like the back of their hand, table 5 basically shows your staffing and your FTE counts. It also shows the visit counts per those staff, as well as just the total unique patients for that time period per the major classifications like medical or dental. I think optometry is even one now. Behavioral health is one. So it kind of helps you see things from what I call the productivity level. 9D is your what I call patient payments. They call it anything patient related. That's your Medicare payments, Medicaid, private insurance, and your private pay patients, your sliding fee scale patients. That's 9D. 9E is all that other bucket, which is basically who gave me money that wasn't a patient. The federal government, the Section 330, the COVID grants now are in here, private foundations, donations, and even what did I use out of my own reserves to fund my business operations for that last year. So these are the tables you're going to want to do. I'm a big proponent of using those on a monthly basis. People that have gone through my dashboarding course, we use these tables to build our dashboard. And I do that for a very purposeful reason, is because you always want to be able to compare and contrast your operations with others around the country, with others right in your backyard, with others in your state, others in your region. So if you stick to these tables to build all of your dashboards, it's going to be easy for you to compare, quote unquote, apples to apples. But run those monthly, because just to do this every year, and I even say every quarter, doesn't help you shift quickly or turn on a dime if something's going on. We actually, in most of my health centers, we experienced the downturn from mid-March, and then some of them had all the way till the end of May before they saw the crash. We actually did weekly UDS tables. That gets a little crazy, so I might be a little bit off on a tangent there. I don't know that I would recommend that as a retrospective, but we did it so we could see exactly what moved when. And then when did the revenue actually move, AKA stop. Like, I had to stop dental at the end of March. My revenue stopped April 20th. So we just kind of did that so we could understand what was going to happen next year. Compare all of this to your budget. Those of you that do annual budgets and then just divide it by 12, you may not see those seasonality shifts. So I would invite you to try to look at your production seasonality and then use that to do some sort of fine adjustments month by month to your budget, if you just do a budget for the entire year. And most people do it that way. Compared to last year, that same month, compare it to the nation. Of course, you can't do that because there's no national UDS that's a monthly issued report, unfortunately. But at least you can kind of get a feel for it if you look across the nation and get a feel for, okay, how did they end up at the end of 2019? And then, of course, compare that to state and local. For city regions, we usually compare just to that city itself, like Los Angeles or any of the other big metropolitan statistical areas. But for my rural counties, like the people I work with in Arkansas, we were actually comparing the actual independent health center data that we could get for their service area and a little bit outside of it that seemed to be actually running on the same level. Don't forget about table 5, looking at patient visits, those visit types. And what I mean by that is, was it telehealth? Was it a phone visit? Was it a check-in? Was it a live visit? Those types of things. Look at it by service line: medical, dental, behavioral health, optometry. A lot of people did OBGYN as a separate one, of course, because that's a different specialty inside of your primary care or your OBGYN practice. Try to look at it from those. And locations. We actually had some locations earlier, but we didn't really, we saw some locations stop, like obviously school-based health centers, they almost came to a screeching halt. But then we saw other locations that didn't really get affected that much. So it's good for you to actually look at all of them. And don't try to presuppose what's going to happen. So you kind of self-limit your review. If you start a review like this, review every piece of data so you can learn from it. And then another thing I measured was revenue efficiency. So what I do with this is I basically just look at the visit type to the amount of revenue that came in. And again, looking at that over those monthly periods is really important. The visit type to the provider time. We actually, and I didn't put this on the slide, I should have, we had provider remote, provider live, because you're going to see a difference in productivity. And again, we get into that in a lot of detail in the productivity one, but you're going to see a difference. Some providers did exceptionally well being remote. Some of them did exceptionally poorly. So you got to kind of understand, was that a difference in a difference between providers, or was it a difference between provider types or services? So it's kind of like why you want to try to grab all this data as best you can. Visit type to quality measures. So we also studied, and I think most of you guys have done this study. So we kind of had this presupposition that obviously people not coming in, we can't close quality gaps. So some of that went down. We looked at it to kind of measure that. And that is what we found, is that the patients that were coming in live, their quality scores went down for most things, but some of them went up. We actually had people going to the laboratories a lot more often for some reason in one of the cities. And I don't know why, but they're actually, some of their quality scores that have to do with actual clinical measures like lab work improved. So who knows? Visit type to clinical outcome. This one studied, and this one's a hard one if you guys haven't made the jump to value-based care yet, or value-based care awareness. But that's things like looking at utilization of emergency departments and inpatient admissions, things of that nature, compared to the types of visits that that patient had. And it gets down to the level where you've almost got to have an analytics system to do it, but most of the computer systems can output the information to help you do those studies. Value-based care, this is more of a macro level across your entire population that you manage. If you somehow have a Medicaid contract that's paying you by utilization, get a hold of that subset of data, try to define that control population, AKA all of my patients that are with health plan A during a given year, and health plan A being that Medicaid Advantage plan, and kind of look at your utilization against the UDS tables just for that subset. Most of the packages now, the EHRs will actually let you print out UDS tables by insurance plan or by office location. If yours doesn't, see if there's a way to get the raw data to do that. But this kind of a study can also help. We found that, of course, with COVID, the value-based care just went haywire. In some places, it actually got so good because people weren't going to the hospital and we were doing such a good job of helping them at home. Other locations, mainly in the big cities, we saw surges in emergency room visits, obviously. Not even COVID-related diagnoses, but just things that they go to the ED because they couldn't get in to see their providers. So again, just look what happened. Did you see a trend? Did you see a sudden shift? You know, these are things that are very important that you can look for, spot them, note them, and then come back and try to figure out what happened. So now that we've been through one, let's talk about how to deal with the next one. And again, that can be any emergency, whether it's national, regional, or just your health center. One thing to do is find downstream revenues. I did this a lot during COVID. I always do this anyway because I find health centers, most of them, lack the ability to bill for all the things that they are providing. So I would invite you to kind of look at everything you're doing and then look into the coding to see if that's extra money you can squeeze out. A huge one is chronic care management and Medicare. If you have a big Medicare population, that's kind of the easiest low-hanging fruit to start there. But even a lot of the Medicaid plans have started paying, if you sign those agreements with them, they're paying a PMPM, per member per month, to do chronic care management, things of that nature. So just try to look into that. The follow-up visits, that's a quality issue as well as a potential revenue stream. Just make sure your people are being recalled back to the level they're supposed to be. Find and build your cash reserves. 180 days is really the minimum days on hand that it's recommended for a health center now. I know that's a lot for a lot of people. I've had some that are, barely squeaking 20 or 30. I've got some that have a whole year in reserves, but find it and build it. And we'll talk a little bit about that in the costs to be able to help you do that. But when you calculate the 180 days, calculate using like 2019 numbers, production and costs. Some people will say, no, I'm going to use 2019 production numbers because that's part of the calculation, but I'm using my costs from 2020 because, COVID obviously increased our costs. So that's an even more conservative method of doing it. Get a line of credit. Your local bank is probably your best place to go. If you don't have a line of credit, I would really, really, really recommend you get one of those right away. You can go to non-bank. There are some non-bank sources now that do not-for-profits, especially non-for-profits that are in the healthcare arena. And then your donors. You'd be surprised how many donors that are big donors may even help co-sign for you to get a line of credit. You can free up restricted assets. This is for you CFO types. I'm probably boring the other folks, but sometimes you have restricted assets on your books that you can't use for emergencies. A couple of my boards that had significant restricted assets negotiated back with those entities that donated those assets to be able to use them in times of emergency, and basically unrestricted them when an emergency hits. So understand the changing reimbursement. We talked about this. Fee for service going into value-based care. The value-based care sometimes can just give you capitation revenue month in and month out, that at least you've got some sort of a definite revenue stream. And more and more of the Medicaid plans are going that way now. Understand your cash flow efficiency. So what this means is, what pieces on this chart actually are more efficient, AKA bring money in a quicker level. These operating margins, these are costs more so that we're going to go into when we get into the cost section. Revenue growth, that's kind of finding those new sources, those new customers, those new codes to be able to use it. And then finally, once you've identified all of this,
David, sorry to interrupt. We have a quick question from Deborah.
Sure.
She says, which EMR are you using that has filtering for UDS clinical measures by payer?
So the clinical measures, what we were able to do is get ECW to allow a script inside of the reports that have the UDS tables, and they can allow you to start selecting date ranges and different service lines of different providers as you run the UDS reports. So if you have that, if you want to contact me outside, I can give you some tips on how to do that. But that's just regular in the regular UDS reporting section. Okay. So what we do is, like we do PDSA cycles for the quality measures, let's do those for all these financial measures and the things that we identify that we need to do to get ready for this. Do your PDSA. use a planning form. Once you do this and you understand all of this, we can use this in your response plan. The response plan is basically you initiate, plan, execute, monitor, and close. You guys that use the FEMA disaster management or the HRSA plan, it's all kind of the same thing. They're all built around that same infrastructure. We just need to add a really robust financial portion to the plans now. They always have a plan, but in their plan, it's more about, okay, how can you finance this? How can you get extra money? It's kind of like very macro level, if you will. The things I'm teaching you today will help you get zeroed in and almost understand, okay, if something happens again that affects dental, this is what I'm going to do. If it affects being able to see people in the office, this is what I'm going to do. You want to get to that level and use these PDSA forms to not only track backwards what happens and do a retrospective study, then project forward, okay, what are you going to do in response the next time? And then you keep going back to this and studying and improving and capturing those things that actually work for the next one. These are some resources. I think you guys are going to get these slides. So these are the tools and things like that that you can use to be able to get your plan put together, study what happened, all of those things we discussed. And I'll stop really quickly to ask if there's any questions. I think we have about 10 minutes. If we don't have time to answer many questions, we can absolutely, I'll send those back to you in writing over the next few weeks. If you have questions.
Hey, David, can I just jump in for 1 minute?
Yes, absolutely.
Okay. So we've got 10 minutes left. And as everybody knows, or hopefully knows, this is a 4-session learning collaborative. Next session will be April 7th. Then we've got April 21, and we're going to finish up on May 5th. One quick note, we had originally said that the productivity session was going to take place on the 21st of April, and the staffing section was going to take place on the May 5th. And we're going to flip-flop that. So productivity will be on May 5th, and staffing will address on April 21st, and that will facilitate some other participants and another speaker to join us. So we're looking forward to that. The other issue is kind of going forward. You know, we talked internally, would folks be interested in office hours? And in constructing this thing, we realized these sessions are only an hour, but we know everybody's time is tight. But if people would like to do an office session or a office hours arrangement, if you could drop that into the chat and just identify, you know, some times of the day or days of the week or something that might work, so that we could set up, you know, 1 or 2 of those. If folks are interested, you know, we'd like to do that, you know, going forward. And then lastly, of course, got to complete evaluations, because HRSA needs those evaluations and we need them, so we know what, you know, what to change and improve on and what you like and you don't. So please do that. And then for the next few minutes, if folks, and I know you guys aren't bashful, I know, you know, we've been working with health center people for 20 years, and I don't know a shy one in the group. If you can, put your camera on and feel free, as part of, if you have a question or if you want to discuss, you know, just speak right up with it. So Fide, I don't know if you can, if you have to unmute people one at a time, or if you can just unmute them. But can we give that a try?
Yep. Yeah, definitely.
Okay. And I know that I know Deborah Lehman is particularly engaged. So Deborah, you put a lot of, you know, questions out there. So I don't know if you want to just jump in and any thoughts or questions, or on the flip side, any promising practices that you may have had on the revenue side.
Well, I will allow my CFO, Pam Barnes, my partner, is on this as well.
Okay.
So I will leave the financial and the revenue in her capable hands. But I've been really anxious to kind of debrief about this whole COVID experience that we've been through this past 2 years. So very interested and I'm so excited about this opportunity. And really, we had to learn so fast, so quick, and we had to be so agile that one of the things that we did every single day at 8 a.m. was my entire operations team had a huddle. And we started every day from 8 to 9 or 8 to 8:30, whatever time would allow, to really talk about the blocking and tackling. How are we going to keep our patients and our staff and our community as a whole safe in the environment that was very quickly deteriorating and declining and impacting our patients and the health of our financial health of our medical centers. So I'm just really very excited, and I hope that it really this initiative will help position us for the next crisis, whatever that is happening to be. There's all kinds of things happening in the world right now, and any number of those things could certainly have an impact on our federal community health centers. I know our current president and leadership is very focused on our medical centers and FQHCs to support whatever the initiatives are at hand and the priority that is dictated. And so we just want to remain in a constant state of readiness. We were very, very fortunate. We received, of course, all of our PPE through the National Stockpile, and then our partner at the state level, Texas Association of Community Health Centers, valuable resource. We were on webinars with them almost every day, and then 3 times a week, 2 times a week, and really until things stabilize. So I'm really interested in all of your feedback and any operations people that might have joined this learning collaborative like me, hoping to really feel better prepared as we move forward. So I really appreciate this very much.
And Deborah, what health center are you with?
Health Services of North Texas. We're based in Denton, Texas. We have health centers in Denton and Collin County. It's just, our growth has been over the past 3 years has been very great. As you know, Texas in general is a real hot spot for people, all demographics. So while you can say that, only this demographic is moving to Texas, that's not true. All the patients, patient populations, and particularly those with many socioeconomic barriers have relocated to our area as well.
Okay, great. I'm going to just jump over because we don't have a lot. Yumiko, would you like to introduce yourself and just kind of tell us what your thoughts are?
Yumiko Molden. I'm with Waikiki Health Center in Hawaii.
Oh.
I am new to Waikiki Health. I saw your webinar was available and I said, you know what, I need to jump in there and learn as much about UDS and, preparedness for what could come up next. And so I'm very excited as Deborah to be a part of this and to learn what I can. I'm the Director of Revenue Cycle here.
Oh, perfect. Okay, excellent. And, a question for you and Pamela. I mean, I'm just curious with the funding for uninsured kind of expiring, is that going to impact you guys very heavily in your health centers?
I think that it is to a certain degree, but we also have other funding and grants that we utilize for uninsured and underinsured patients. I believe the FEMA that just expired on 3/22 for the claim submissions really didn't have an impact on us because we hadn't really received any denials recently for those COVID, transactions or treatments or visits. So that really, I don't think is going to impact us. But if the current funding for HRSA does expire or gets exhausted, it is going to have an impact.
Okay, Pamela, how about North Texas?
I'm going to agree that the COVID uninsured portal funding is going to have minimal impact on us. I think, some of it is going to have impact on the patients because what we've done is we've continued to charge our patients, but then we've refunded when that's paid. So we've created a little bit of an admin burden on ourselves, but then we kept that payment cycle going so that the patients don't get used to not paying, which is a huge, huge issue. with our health center. You know, we have the free clinic mentality throughout our community, and you know, and so that's probably one of the barriers that we have in our marketing campaign. Couple of things, and I'll try not to be too long-winded. I believe the barrier to medical care is called medical payer credentialing. I think that's the hugest barrier to care. You know, when we were told when COVID hit that all these credentialing processes were going to be relaxed, we're going to bring people in out of retirement, and we're going to relax that. The exact opposite happened. I now have to tell, you know, the medical payers when the babies were born from my providers, why they had a 6-month gap in there. And maybe that's normal, but I mean, it just exponentially got worse. And specifically here in North Texas, we have 14 different Medicaid managed care organizations. And then, you know, then the marketplace hit. And what I think the government needs to understand, the general population needs to understand, is health insurance is not medical care. It is a means to pay for medical care. Obamacare is not medical care. Marketplace insurance is not medical care. We are medical care. FQHCs are the medical care. And until we can flip our conversations, nothing's going to change. I have 14 different medical care managed care organizations, and they asked me to bill differently, all 14 of them. They asked me to credential all 14 of them. Denials is the biggest barrier to us getting paid and credentialing. And I'm on a rampage, and I'm going to get to the President of the United States and change this, because that is the barrier to medical care. When Obamacare hit, they had all these insurance companies, all these for-profit insurance companies go, yay, I have a new revenue cycle. But then they realized, oh my gosh, these are sick people that are getting on this plan. So we have these high deductible plans, these high risk plans that people are paying for that none of us could get credentialed with. I have 3 or 4 marketplace insurance that has taken me 3 and 4 years to credential with. And these patients are coming to us expecting to, you know, pay their copay or whatever. And we're still not credentialed with them. You know, I can name them off if we need to, but that is the barrier to medical care.
And the ones you're talking about, most likely. Yeah. Universal credentialing. Yeah. I wish. And that was CAQ.
They talked about, you know, going to AAPCHO. And I don't know if that's just Texas or what that is, but AAPCHO added another layer of somebody else that doesn't understand how to credential us. So that just, you know, the plans go, oh, nope, you got to talk to AAPCHO. There's no live person to talk to, no email, no nothing. And we just get blankness. And, you know, that is my biggest point of frustration. And Deborah has heard this from me forever. And I will continue to stay there, because that is the barrier to us getting paid. I can't tell you how much I have to write off. I can't tell you how many times I have to call these 14 different Medicaid companies and them tell me the same answer to the question that's not solving the problem.
Okay. Well, we're coming to the last couple of minutes. We're actually a little bit over time. We'll stay a couple of minutes for people who want to stay. And I'm just going to throw out to anybody else who would like to jump in, like Saul, Dolores, Georgina, Mary, Anya. You know, again, don't be bashful. And so I'll give you just a minute. And then from Pamela Yumiko, just curious, does the office hours things seem like something you'd be interested in? And if so, like, as I said, you may have already put in the chat, you know, dates and times that might work for you, or if you're interested, but we are curious about that.
I think so, but I have to tell you guys, you know, I think all these great plans of having meetings, they're starting to wear me out.
Yeah.
I've been in this business for 28 years and I'm 29 years old. So, you know,
Which is amazing.
And, you know, all these great plans to do all this theory of rehashing what happened in the past. I honestly do not have the time for that. I have now to deal with, and patients, 17,000 patients now to deal with. I understand the value of trying to see where we came so we can know where we're going, but we need some action. You know, I'm sorry to say, but there's a lot of talk and no action happening.
Okay.
I'm a get her done girl. I just went through the Myers-Briggs.
I think we got that impression. Okay, well, and then on the topic of office hours, I don't know if that's something of interest to you or not. And Yumiko, if you
So I don't really understand what you mean. Is that just an area for us to
well,
talk?
basically during the sessions, of course, there's a pretty good chunk of didactic where, David's delivering, information and so on. There's not a lot of time for interaction, and people may have specific questions or problems that they want to drill down on. And so that if we set up a couple of office hour sessions for folks who would be interested, we could get into more of that. Maybe we could talk more about credentialing, for example.
Yes, I would be interested in that.
Okay.
And you said to put in the chat sometime.
Yes. And days are and approximate times, windows, that kind of thing.
Okay, I'm interested in that as well. I'll look at my calendar and see when I have some free time and drop it in there as well.
That sounds great. And I see Dolores chimed in and she's in agreement with Pamela. So, okay, good to hear that. And David, we're just about out of time here. Our next session is April 7th, and we'll be getting out to you the slides and so on for today's session. But David, any last words?
A look back, review, study, and get ready for the next one.
Okay, and anything people could think about in preparation for the cost session? Is there any? I think we lost you there.
We're good. Thank you.
David, I don't know if can you hear me?
Yeah, I can hear you. You can
Just
hear
asking,
me?
is there anything that you'd like people to think about in preparation for the next session?
Oh, so what if you could somehow pull your financial statements and see if you can do comparisons across 19 and 20 to see what costs went up. It would be a good discussion. It'd be good to get you ready. So as we're discussing those different topics, you can kind of share with your peers and counterparts. Because during that one, we're going to talk about cost containment. So that's one of the things. See where the costs went up and maybe things you did to help them stay reasonable or go down. Yep, that would be it, Robert.
All right. All right. Well, thanks, everybody. It was great getting to meet you, and really enjoyed the first session. And we'll see you on April 7th, and we will get back to you with some possible times, dates for office hours. All right. Take care.
See you. Bye-bye.